Good afternoon, ladies and gentlemen. Welcome to our second webinar for the year. And we're discussing a very crucial discussion on cervical cancer. And we thought it's more important this time round to discuss where we are as a country, and in conjunction with the Ministry of Health and many other organizations like KNH-UoN, STOP. We have several panelists today to discuss crucial matters, and each panelist will probably have 20 minutes, 15, 20 minutes to give an update on the session. And we'll begin with Dr. Chemutai Munga, who's the Associate Professor and an obstetric gynecologist in the University of North Carolina. She is to give us updates on the status of cervical cancer and yeah, Dr. Chemutai, in terms of research elimination, and you can give us your take on strategies on going forward. Welcome, Dr.
Thank you so much. Okay, all right. I think you can all see me, and hopefully the internet will cooperate. So I'm really happy to be here. My name is Dr. Chemutai Mungo, as has been stated. I'm a gynecologist, and I'm a professor of OBGYN. And I'm very passionate about this issue, and I work in research with the goal of elimination. I think the key thing for everybody to realize, and most of us are clinicians here, is that this is a cancer that we can prevent. And indeed, any woman who dies from cervical cancer is a failure of the health system. And, you know, we call it that it should be a reportable death, because it is a death that can be prevented, because the science is very, very clear. And that's why the WHO has initiated this elimination agenda, because unlike other cancers, for example, Professor Wangai Maathai died of ovarian cancer, which we don't know how to screen for. The richest woman in the world, we do not know how to find ovarian cancer early. But cervical cancer is not one of those cancers. It's a cancer that we know what causes 98% of the cases, which is the HPV virus, which is why if 90% of all girls in Kenya and in Africa get vaccinated today, in 20 years, no girl or woman needs to be dying from cervical cancer. Similarly, we know how to screen for cervical cancer compared to, again, ovarian cancer. You could be the most wealthy person, have access to the top-notch healthcare, but we cannot screen for ovarian cancer early. Unlike that, in cervical cancer, we have what we call a latency period of 10, 15 years, where a woman who has been exposed to HPV has early changes in the cervix, which can be found through screening and can be completely treated. They do not need an oncologist, which is a cancer doctor. They do not need, very comprehensive or expensive surgery. It's treatments that can be done in the clinic, or at most it could be a simple hysterectomy, which many medical officers actually know how to do, simple hysterectomies. The point is that let's internalize the fact that this is a very preventable cancer, and indeed any woman who dies from it is a failure of our health system. And how do we quickly work building on the initiative of the WHO to fill the gaps? We have the vaccine in Kenya, so our goal should be every year we should double, or at least increase by 25% the rate of girls vaccinated, so that in 10, 15 years, we can say that 90% of girls have been vaccinated. Similarly, and many of my colleagues here will talk about this, that any woman anywhere in the world, in Kenya now, our question should be, how do we get to 70% of women screened with a high quality test by a healthcare provider who knows what they're doing? And lastly, any woman who has presented to a health facility who has been found to have precancer, or early signs of cancer, we need to make sure through these conversations that we close that gap, that we don't let women, access to, if they need to go, if they're in rural Migori, for example, I'm currently in Kisumu. If a woman is in rural Migori and needs to access a gynecologist to do a simple hysterectomy, the cost of fare, which can be, 3,000 shillings, which for Mama Mboga is a lot of money. But how do we make sure that with universal healthcare, this woman who presented to a facility was found to have very early signs of pre-cancer or cancer and needs to come to Kisumu? How can we make sure she gets there, gets a treatment quickly when it could be cured, and not let her wait because she's waiting to raise that money for a whole year or two? Next thing we know she has progressive disease, it cannot be treated. So again, Catherine Kasavoli, how did the system fail her? Because she's in a place that has access to gynecologists. So what is the stigma that's causing women not to present to health facilities? Is it lack of knowledge? So, a lot of these webinars are presenting this knowledge. How do we close that gap of vaccination? We have the vaccines, access to screening, making sure 70% of women everywhere in Kenya get screened. And most importantly, the whole point of screening is to link the woman to treatment when pre-cancer can be cured. So how do we make sure that no woman, regardless of where she lives, even in Turkana, is linked to the right healthcare provider who can treat her, that way she never dies from cervical cancer? Thank you so much.
Sorry, thank you very much, Daktari. That was quite informative. I like how you bring in the issue of cost, and at the same time question if cost is really the only issue in factor, because you brought out the personality of Kashavuri, may her soul rest in peace. And I don't think cost is a factor there. So what is the problem? It's more than money, yeah? And what are the gaps, and how we can do what we can do to cover the gaps and make the gaps shorter. So please ask Q&A on the sessions and in the areas of research. I'll get back to you, Daktari. I have more questions, but without further ado, I'd like to present Dr. Lucy Meka. Dr. Lucy Meka is the head of vaccine program in the Ministry of Health. Meka is instrumental. I've had several sessions with Meka. I've never met her, but I know her so well. And Daktari, please kindly update us on matters vaccine.
Thank you so much, Dr. Amina, and good afternoon, everyone. Thank you for this opportunity to talk about HPV vaccine. And if you can allow me, I'll share my screen. Okay, so I'll just take us briefly through our plans and what we have been doing regarding the HPV vaccine program for the government. We are currently targeting the 10 to 14-year-old girls. And just a background on HPV, the situation. If you look at the statistics currently from the data that we have, we know that 9 women are dying from cervical cancer every day. We are reporting 3,000 deaths annually. And it is the primary cause of cancer death among women in the country. And if we don't do anything, we are going to double this number. It's estimated and projected, but God forbid that this happens, we'll get to 22 deaths per day by 2040. But at least now from the previous speaker, Dr. Mungo, you have heard that there's something that we can do. There are things that we can do to prevent this. So 70% of the cervical cancer cases are caused by the HPV type 16 and 18. I'm focusing on this because of the type of vaccine that we have introduced, and which is the quadrivalent vaccine. This vaccine has demonstrated nearly 100% effectiveness against these strains. That is type 16 and type 18, which are causing 70% of cervical cancer cases. So, of course, the question is what happens to the other 30%? I know that would be a question. And this, not to belabor this, I know you know the cause of the main cause of cervical cancer is HPV virus, which is easily spread through skin to skin contacts, mainly during sexual activity with an infected person. And we are focusing on this serotype 16 and 18, which cause about 70% of all the cervical cancer cases. There are also other low-risk types that are associated with cervical cancer, but also we have type 6 and 11, which are associated with genital warts. Focused on that because our vaccine, which is the quadrivalent vaccine, it prevents infection due to type 16 and 18, which causes the majority of cervical cancers. And it also has the antigen type 6 and 11, which are responsible for the genital warts. That's why it's quadrivalent. It is a subunit vaccine, which means it just has a piece of the virus, and it is WHO pre-qualified and licensed by the Pharmacy and Poisons Board, and it is presented in 1-dose vials. So this is just to tell you about the vaccine that we have. We are giving it as a 2-dose schedule, administered 6 months apart. 2 doses are required to complete the schedule. We have a new information and evidence from WHO regarding the 1 dose, but we are yet to adopt that. The recommendation by WHO will be reviewed by our advisory group, that is the Kenya National Immunization Technical Advisory Group, before we can now have a recommendation whether to adopt or not. And 2 doses are required to, so for now, 2 doses are still required to complete the schedule. And for HIV positive girls, they should receive 3 doses. The 3rd dose is given 6 months after the 2nd dose. So that will be 6 months apart. And our 2 doses are 6 months apart. We have had experience with HPV before. Before we introduced the vaccine in 2019, we conducted a pilot, which was in Kitui County, and this targeted girls aged 10 years. And we learned quite a lot about that pilot. We reached a coverage of 85% when we conducted this pilot, and it informed us to adapt the current strategy that we are using for vaccination. In 2019, we introduced the vaccine nationally, targeting the 10-year-old girls. And this was done in collaboration with various stakeholders, including the religious leaders and professional bodies. And the strategy that we used is a fixed strategy where you have the vaccine at the facility and people come into the facility to receive the vaccine. And this is complemented with school or community outreaches for those who can't come to the facility. However, over time, we are finding that people less and less people are coming to the facility, and therefore we are being forced to go out. We can see, like, during the time when schools were closed because of COVID-19, we really had a low coverage of HPV. So we had even to conduct a sort of rapid results initiative, that is intensification of routine immunization, to be able to capture more girls. When we started in 2019, we started with the 10-year-old girls because the supply of vaccines was not good. We were promised that we could expand the age group once the supply was better. So in 2020, we were informed that the supply had improved. So we targeted what we call the multi-age cohort. We began in late 2021, November, to target a multi-age cohort of girls who are aged 10 to 14-year-olds, to be able to ensure that we have a high coverage among these girls. And then once we achieve a high coverage among these girls, we'll revert back to our usual age cohort of 10-year-old girls. So we have already made the plans with the counties to target these 10 to 14-year-old girls to ensure that by June 2023, we have captured all the 10 to 14-year-old girls before we revert back to our usual cohort. So if we look at the WHO cervical cancer elimination goals, as you know, it is multi-pronged. We take a multi-pronged approach with the cervical cancer. One of them is vaccination. So as somebody said, vaccination is just one of the methods of addressing this issue. The other one is screening and treatment. So for vaccination, we target to vaccinate 90% of girls by age of 15. Screening is targeting 70% of women, at least are screened using a high performance test by age of 35, and again by age of 45, and treating 90% of women with precancer, and 90% of those who have invasive cancer are managed. For us, particularly for the HPV multi-age cohort, we want to reach 100% of the girls aged 10 to 14-year-olds with 2 doses of HPV by June 2023 to prevent cervical cancer. We want to continue to engage stakeholders, including yourselves, to be able to deliver immunization effectively. And we are also ensuring that we have HPV vaccine available and integrating with other activities that are that we can integrate with so that we have efficiency. If you look at our coverage currently, from when we started, this is the coverage of the 10 to 14-year-old girls. Nationally, we are at about 56%. But you can see the disparities between the counties. There are some counties that are even almost at 0%. And therefore, as if you are a stakeholder in that county, you can really be a voice for us to ensure. Look at Nairobi. Nairobi is in the city and they are at 30, not barely at 30%. And this is the city. You look at the more rural counties, Nyandarua, Bungoma, Kirinyaga, they are doing very well. Now, this is the question. Nairobi, we would expect that people who are enlightened would be really embracing the vaccine, but this is not the case. HPV2 is also at low, at around 30, just barely reaching 30%, at 27%. And we see the same trend with the counties that are in the northern frontier doing badly, but even Nairobi is close to that, which is also an issue. While you can see the other counties, the more rural counties are ahead, but still we are not at the 100% that we want to be. And so some of the challenges that we are seeing, issue of demand, inadequate knowledge on the HPV vaccine. Much as we think that people could be enlightened, we know that there are people who don't know that this vaccine is offered in as part of the routine vaccines. We have seen myths and misconception affecting particularly the northern frontier, where there was a big rumor about the vaccine and about it causing infertility, which really has caused we are seeing almost 0% in that frontier, and we keep on to engage and see how we can support. We are seeing also issues of indirect costs that were mentioned when we did a survey: fare to take the child, extraordinary working hours of the caregivers, and then issues of consent, which has really affected some of these urban settings. And then we are seeing also issues of some artificial stockouts. Some facilities were thinking it's a vaccine for the higher facilities, but we inform them that all the facilities that are offering routine immunization should also offer the HPV vaccine. So we are seeing that our best practices, some of them, we need to continue to schedule outreaches to schools, places of worship. Another thing is whole site orientation. Like if you're in a hospital, wherever you're working and you get in contact with any of these girls who are 10 to 14 years, please refer them for vaccination. When they are being assessed for other things, they should also be assessed for vaccination, just as children are assessed. We have also integrating HPV with other vaccination programs for the same age group. When we are going out for COVID, we also go out for these other vaccines, and we continue to engage the media and other stakeholders like religious leaders to ensure we are all on board. So I would like to thank you so much for this opportunity, and back to you, Dr. Amina. Thank you.
Oh, lovely. Thank you. Thank you, Dr. Lucy, for that perspective. I've just learned artificial stockouts, as in it's something that I know happens, but I love that it has a name. So next is Lillian. Lillian, Lillian, can you hear me?
Yes, hello, I can hear you. Please make me a co-host.
Pardon?
Please make me a co-host to share my screen.
You can share even as a panelist.
So good afternoon, everyone. And thank you for joining this call. I'll take you through cervical cancer elimination. My name is Lillian Genga, working with National Cancer Control Program. I'll take you through cervical cancer elimination in Kenya. So we'll just see the burden of cervical cancer in Kenya, the policy framework, global and local, and then what we have done and challenges and the way forward. So the burden of cervical cancer in Kenya. In 2020, Kenya has is an estimated 5,236 cases of cervical cancer in Kenya. That's around 12,000 of cancer cases, and with over 3,000 annual deaths, and it is actually the cause of all cancer deaths. As we can see, breast is leading in incidence, but cervical cancer is the second one. Then again, we are seeing cervical cancer now leading on deaths. So WHO has launched a cervical cancer elimination strategy, dubbed the global strategy to accelerate the elimination of cervical cancer as a public health problem. This strategy identifies the key interventions and targets for countries globally by 2030, also known as the 90-70-90 cascade. And this means 90% of girls fully vaccinated with the HPV vaccine by age 15. And again, 70% of women are screened with high precision test. And then 90% of women identified with the cervical cancer disease receive treatment and care. So to track the progress towards these targets, the WHO has also proposed several indicators, which includes HPV vaccination coverage, population level screening programs using HPV testing, early detection guidelines, and also defined referral system. And as we can see, we have a very beautiful photo there. The lady is a cervical cancer survivor, and the girl is the daughter who is a champion of HPV vaccine in Kenya. So as we see this graph, it is just presenting how we have screened the women in Kenya. We have HIV positive women, and also we have HIV negative women, and we have the totals. So if we see between 2017 and 2022 June, we are seeing the graph. It's actually not moving much on the HIV positive women, which are most likely to get the HPV virus easily. We can see in 2018, when we compare with the average that we are supposed to screen, that is 800,000, there were only 18,000. That is in July 2017, 2018. And then we see the orange one is women living without HIV. There were 2,336,613. And then the totals were 2,554. If we see this trend as it's moving year by year, we are seeing we are not there yet, even as currently, this is currently just recently 2022, the total screened was 680 and 19. We are still below 8,000. So meaning that the screening uptake is not doing very well in our country. So we have life course approach to cervical cancer prevention and control, where we have these measures where there is a between the age of 9 to 15 years, we are supposed to vaccinate the girls with HPV vaccine. And if we vaccinate it, if we follow it, you'll see that the HPV is low. Then again, if we do screening and we do treatment of precancer lesion, also again, we are lowering the deaths. Again, if we treat those who get that are already now having the disease, we will eliminate cervical cancer in Kenya. So we have 3 ways of fighting cervical cancer. First, we have primary prevention, secondary prevention, and tertiary prevention. So on primary prevention, in Kenya, that is 10 to 14-year-old girls are supposed to be vaccinated with HPV vaccine, as Dr. had said earlier. Then we are also supposed to do advocacy to girls and boys appropriately. They are telling them health information and warning about tobacco use and sexuality education tailored to their age and culture. Also, we promote condom use where they have already engaged in sexual activity. And also we promote male circumcision. Then on secondary prevention, that is in Kenya, a woman between 25 to 49 years should be screened and treated, which is a single visit approach. You go to the facility, you are screened. If you have a lesion, you are treated there and then. And again, we have point of care and rapid HPV testing for high-risk HPV types, again followed by immediate treatment and then on-site treatment. So if you get that you're having you are HPV positive, we test properly, and then again we do treatment as required. Then all women also as needed should get treatment of invasive cancer at any age, and palliative care, that is the tertiary prevention. And then they can get ablative surgery, radiotherapy, chemotherapy, and palliative care. So what have we done to eliminate cervical cancer? So we have worked very hard and came up with on advocacy awareness. We have developed cervical cancer advocacy guide, which in 2020, and it was launched for the opinion leaders. And also we also developed IC materials. So again, on advocacy, we have trained 200 champions. Again, CHV manuals also were developed, and 200 CHVs also trained. So we have CHVs who are at the grassroots level and can reach our community where they are. So again, we have launched e-learning platforms where healthcare workers are getting trained. Also, we have HPV testing pilot for cervical cancer screening. This was done in 2019 up to 2020. We have a very beautiful report which is out on it, and the HPV testing is now going on. Again, we have a National Cancer Preference Laboratory. This is where we are testing HPV. We are doing HPV testing, cytology, histology. Actually, they get samples from all over the country. We receive samples there, and they are processed. Again, we have trained all the county lab staffs, which are having gene experts to test HPV at the facility level, at their facility levels, and also mentorship have been done to them. Then also we have data tools. We have also developed EMR and also piloted it. We also did a baseline data collection for cervical cancer, and this one made us now to do implementation as follows. We have trained TOTs, 540 of them, and mentored them fully across the country, across the 47 counties. Then again, we have trained over 6,758 healthcare workers in 46 counties. Actually, only one county is remaining, that is Lamu County, which its training has also been planned to happen soon. And again, we have trained 53 KMTC campuses. We've trained their lecturers so that training begins initially when you get into college, not after service. And then again, we have trained 60 Kenya Defence Force workers. Also, screening are going on in those places. Also, and again, we have mentored, and we have mentored part of them, and some mentorship planning is in progress. Again, we have trained over 228 LEAP users. Those are the doctors, gynecologists, and the clinical officer RH also have been trained on treatment with a LEAP device. Again, we have distributed thermal ablation devices and placed them in 25 counties. And there is a plan underway to place on 22 counties. And again, we also placed LEAP devices in 25 counties where they were trained. Right now, also colposcopy were issued to 20 facilities, and there are still 30 more to be placed, and colposcopy training is currently going on. On supplies and commodities, also we have provided them where we receive from partners, where we get like the thermal ablation machines, the LEAP machine, speculums, acetic acid, gloves. Also, we have tried to provide to the facilities in the counties. So county lab activated to provide HPV testing and cancer specimen handling. This was also done across 25 counties. We have trained and mentored the lab personnel. Also treatment. On treatment, we have launched 10 county chemo centers and 3 radiotherapy centers and palliative care policy. With all this, we still have challenges, and which if we are act on, I think we'll we will try and eliminate cervical cancer in our country. There is awareness creation. This is very low, and when we expect that during when at the waiting areas of facilities, we could be having some health awareness where you talk about cervical cancer, at the same time you talk about vaccine to the same women who are being attended. So awareness creation is quite key at all levels, where we started from the grassroots to the higher levels. Then also screening uptake, access to diagnosis and treatment and linkages to care. This also has been, we are seeing it is a challenge. Despite the training, the screening uptake is still not coming up. So either we change our attitude and we act on now, as we were just given a story of Catherine Kasavuli. It is real, and if you are trained, you are supposed to give care where it's needed. Again, integration within the healthcare facilities. This one also is very key, where you find that a laboratory could be having the HPV vaccine and the MCH are supposed to order from them. You find that they still expire and they're within the facility. They're not being used. So that is causing a lot of wastage, where we can use these commodities. And then again, training and mentorship of healthcare workers. This is needed, as those who have been trained would also do OJTs to those that have not been trained, and still the facilities are supposed to organize at least for CMEs and train healthcare workers, so that awareness is created also within the facility. Then we have continuous quality improvement teams. This, we went across the country and we found that cervical cancer does not have a QIT. So we are just encouraging that you integrate it in the existing QIT, like for HIV, in the TB, so that it is also captured there. Then we have supply chain management, which is also a problem. If you go to facilities, you'll not find that they have an inventory for cervical cancer. So you will not know whether the commodities are finished. You are supposed to order again. This should happen just the way we do the vaccines. so that you monitor, you have an inventory book where you enter, when they are finished, you order. Yes, as such, we will not be having shortage. Again, we have data management. Under data management, if we only could use the data tools that are provided, that is the screening register, which is a daily attendance, and then we also the summary data tool. If we use them well, we will capture the data, because work you do and you do not document is work not done. So you could be working so hard and you're not using your data well, and this is not reported, and it gives us this low coverage, and when we see the uptake is very low. And so, as I say, stop cervical cancer by screening, you do treatment, give optimized diagnosis and referral, and again, remember to do primary prevention by vaccinating the girls between age 10 to 15 years. Thank you.
Thank you. Thank you very much, Lillian Genga, and many apologies. I did not properly introduce you, but you've been in the platform for a while, so I thought it was default setting. So thank you again for briefing and giving us updates on what's happening in the ministry and in Kenya as an overview. So now we'll start the Q&A session. I'd like one of the slides you posted on the data on cervical cancer, where we at, and you use the global can studies. So in my review of the data, Kenya I compared with East Africa, because it's also good to know where we are in East Africa and also with South Africa, considering that we have 12%, which is the second most common cancer. We also have in Uganda, it's the first, in Tanzania, it's also the first with over 20% prevalence. And in South Africa, it's 9.9. So that's where we are as a country, but what's the vision? Any of the panelists can answer. How do you, are we benchmarking with other countries, let's say like South Africa, since it's attained a lower prevalence, to see what other strategies can we use to make our rates go lower? Dr. Chimtai?
Was your question related specifically to vaccination rates comparison,
No,
or globally?
It's basically the burden, the disease burden, because it's always good to have a picture of what's happening in other countries as well, especially our neighboring countries where we have more or less the same GDPs and the same structures. So kudos to Kenya. It seems like in terms of preventable diseases, we don't have a lot of preventable cancers, and the rate is lower. But what next? What strategies can we apply more, and how can we be better? Like even according globally, because it's not there in other countries.
I think that, Kenya compared, for example, to Malawi, where I also work, we have a lot more doctors, we have a lot more gynecologists. We're not the poorest African country, which means we should be leading, which again is another way of saying any death from cervical cancer in Kenya, which has, about five residency programs are training gynecologists, compared to Malawi only has one. Any death from cervical cancer in Kenya, I think, is a failure of us as physicians, as public health, because we are not at like DRC. We are not, we are actually pretty wealthy if you go to other African countries. I think the key is really, and somebody asked this in the questions, is impact in the next 10 to 15 years. And we have to focus on the the second 70, and the third 90. So the fact that the vaccination, 90% vaccination, we won't see that benefit until we're, in 30 years. But, for the women whose lives can be saved in the next 10 to 15 years, we need to make sure all women are getting screened. So, even in capital cities where there's so many doctors, what is the stigma, concerns, challenges that's causing women not to present to screening? And then, once women have been screened, how do we make sure that we really close that treatment gap? Because I think screening is actually happening. There's a lot more awareness, like the National Cancer Control Program is doing an excellent job of training people, like as was said, community health workers are being trained. So there's still challenges with, for example, women come to be screened, but only one nurse, has a queue of 30 people. So people go, because they've been waiting too long. And I think these are the same challenges that are related to strengthening the health system. And, just to, as an example of how preventable this disease is, I did my residency training. I trained to be a gynecologist in the United States, and I did medical school in the United States. And I have never seen a woman in the wards in the 4 years of medical school and 4 years of residency or being a registrar, never seen a woman who's taking her last breath in the gynecology wards because of cervical cancer in the United States. And that's very common because the health system is quite strong and it has closed at 97 to 90, and particularly the screening and the treatment. Unfortunately, most of you who are healthcare workers know that that's not the case. If you go to Jaramogi now or any county referral system or hospital in Kenya, many gynecology wards have women who are in the late stages of their disease. So again, how do we close to get impact in the next 10 years, 15 years? How do we make sure that the screening is happening and then address the issues of closing the treatment gap so that no woman in the next 5 years can die when it could have been prevented? Because really that's the point. It's like, if the health system is working, no woman needs to die from this disease.
Yeah, thank you very much for that, because if you look at the patterns even of cancer burden in Africa per se, we don't even have lung cancer, but it's a very interesting pattern. So Dr. Lucy, in regards to vaccine, there are many questions on the platform regarding vaccine about scale up, where they are available and where we can get it. So the question is, apart from telling us where the HPV vaccine is, and thank you very much for broadening the age gap from 10 to 14. Now we have at least an age group. You had shown us that Vihiga had the highest number of vaccine uptake. Does it correlate with also the disease burden in cervical cancer? And do you think there's a pattern in terms of places where they are affected with the cancer have higher uptake? Dr. Lucy, sorry, I asked so many questions.
Yeah, thank you very much for that question. Actually, if you look, we've not really seen a correlation with the burden. First of all, because the data on burden is also challenging to disaggregate. And again, also, generally, we are not seeing a correlation. I think also the issue of the data quality is something that we have a challenge with. So we can't really see a correlation, but we found that we can see the counties around the center of the country, around the western part, they have really embraced the vaccine. But we are seeing a challenge also in the urban area. In the urban area where we expect to have more enlightenment, we are not seeing the uptake to be as high as it should be. And then we have the other areas, that is the northern frontier, where the issue there has been an issue of rumors and misconceptions about the vaccine, because someone, there was a religious meeting in one of the counties, and whatever was spoken in that meeting was communicated to a number of the counties around there, and this really dented the program. We couldn't kick off well in those counties. So we are trying to undo what happened then. So mainly we are not seeing a correlation, but we are seeing more of, the reasons why the uptake is not there. Thank you.
Thank you, Dr. Ari. And in terms of technology, have we, what advancements do we have in terms of HPV technology?
For vaccination, we are trying to use the use of what we call geographical information systems to be able to map out where these girls are, mapping like schools to facilities, so that when they do their planning, each facility has been allocated a school within their radius to know that they need to ensure that they vaccinated all those girls in that school. So that is one way we are using technology. In the future, hopefully, we'll be able to have electronic registers that will help us to know, to the granular level and the patient level who has not been vaccinated. But currently we are still manual. So that is one way that we've used technology. Thank you.
Thank you. Thank you. Yeah, Dr. Cheptai, I was just about to ask you, please put it your input.
Technology is certainly our friend. And, thankfully we're at the time when it's a lot more accessible. Many people have access to a smartphone. So, somebody asked in the chat that, the training of healthcare workers, currently it's very, Simon Rambogo, it's very, the training is very resource intensive. It's supposed to be 5 days. So technology can help us bridge the screening and treatment gap through training. So, similar to what Dr. Lucia said about vaccination. So with screening in the facilities, one of the projects we are working on here is how to support healthcare workers who are in the front line. And this actually has been done in Zambia. The WHO is trying to potentially push this in other places where many people have a phone, a smartphone. So if a nurse has seen a lesion that she's not sure whether is this eligible for screen and treat? Does this woman need to be referred? Things like that. In Tanzania, in Zambia, this is happening where, using a smartphone, you take an image of that lesion and it can be sent to an expert who is not in the same place, who can help with decision making. So with training, with bridging the quality gap, especially because if you just do training, I as a gynecologist, there are sometimes when I see a lesion, I'm not sure what it is. I want to take a biopsy, I want to wait for confirmation. And I've had many years of training. So how do you expect a nurse who's had 3 or 4 days only to be able to be as good? You just can't. So that's another way that and I know that the Kenya OBGYN Society, CHAI, other partners here are working on eventually, having, what we call a colposcope where you can take a picture of the lesion and you can eventually share it with experts, in different places to get feedback for the frontline health workers. So this is an area, and there's a lot. So those in the audience who have an interest, if you're an MEd student or you're a master's student, there's a lot of thesis waiting to be written about, for example, community health workers. How do we use, an app that is connected to the health registry, eventually when we digitize the health system in the clinics, where they can identify, who's a woman that needs treatment, or, if you do HPV testing in the community and somebody's HPV positive, you can use technology to link that person to treatment. So a lot of opportunities currently for students, for practitioners to use technology to bridge these gaps that we're talking about.
Nice, thank you. Thank you very much. Lillian, earlier on you mentioned something about e-learning. Do you mind expounding on what on e-learning has to do with cervical cancer? How many days does it take, and how can we access it?
Okay, thank you for the question. We have e-learning platform where we have almost all cancer learning materials have been loaded in them. Cervical cancer has fully all the material from vaccination to screening to treatment loaded in it. The number of days depends with the learner, and after that they are certified when they finish. So actually, when we are using it for training, because it has all the material in it. So you onboard the e-learning. Once you register, we have there are two. We have M-Saratani and Virtual Academy. If you go to the MOH port, you'll get the M-Saratani and Virtual Academy. So once you onboard in them, you'll get all the learning materials there. Thank you.
Thank you, Lillian, for that clarification. And probably later on we'll share the link. You can check on our Twitter handle and also on the MOH platform. So there are a lot of questions on HPV. I'm sorry, we would not be able to address questions on HPV today because the focus is more on this topic is going to be discussed in a webinar on 31st in details on the availabilities, the studies which have been done. But probably, Doc, you would like to give 2 minutes summary of HPV testing, especially because a lot of people were asking on testing. And my specific question is on guidelines. The guidelines are of starting to do the screening is at either 20, should we lower the gap because we are seeing cervical cancer in patients who are 26, 27. Does it benefit us if we lower the screening age, especially now that we have things like HPV testing? Over to you, Dr.
That's a very good question. And again, this webinar being hosted by KNH University of Nairobi, the premier health institutions, I think we need to generate local data because the data, much of these guidelines are based on Western data. So yes, if we're seeing a lot of cancers of young women, we need to document it, we need to publish it, and then start having the discussions. HPV testing, so the Kenyan Cancer Guidelines recommends HPV testing as a primary test for cervical cancer, the most recent guidelines. And it's because it's the best test, it's a better test than VIA. I won't go into details, but basically with HPV testing, you're looking for the virus. It's still not very accessible because it's not cheap. It requires, we're not making HPV tests in Kenya. Eventually, I hope we can get there. Right now, it requires to be imported. It's at least, $10, $15 a test. So, about $1,000, $1,500, which, as we know, it's not realistic to ask counties to pay that much for each person. So if you have access to HPV testing, that is a test that's the best test. And the beauty of the HPV test is that we have very good data that women can self-collect the sample. So, a big barrier to screening, which we're trying to address, is the speculum exam, which, I think we're trying to tell women that while the speculum might be uncomfortable, it's not painful, and it should not be the barrier for you to get a life-saving test. But the HPV test, a woman can actually self-collect the sample, so you only need to do a speculum exam if you have HPV. So in summary, we are moving towards HPV testing. and we're trying to make it available. Until it is available, and most facilities in Kenya don't have HPV testing, VIA should be offered because VIA has been the standard. It works because the science works of VIA. The reason why we recommend starting screening at 25 to 30, is I think my colleague, Dr. Lillian Ganda, mentioned that curve showing that at sexual debut, many people get HPV because it's the most common sexually transmitted infection. So you don't want to screen. So finding an 18-year-old girl with HPV by and large means nothing because, people will get, it's just like home, or maybe even COVID. But so basically the goal is we're looking for persistent infection that has stayed in the body for a while, which is why we, based on data, which is mostly Western, we say, let's start screening a bit later because that big gap of at debut, people get exposed and then most people clear it. And it's only the few that don't clear it, then at risk of getting the abnormal pap smear. So that's the reason why the recommendation is to not start screening with HPV until 25 or 30. But, if we have good data from Kenya, Malawi, etc., showing that for different reasons, the age of incidence is high, is earlier, then that can drive changes. And I think this is a really a strong endorsement for all of us, especially those of us in research, to write those papers, to provide those abstracts, because the Ministry of Health, the people who sit down to write those guidelines, they need to see written data. So the more we can collect epidemiological data, the more it can drive policies that are specific to our populations. Thank you.
Thank you. On that note, Dr. Jinjo Stefan, I hope I'm pronouncing it correctly, is asking, how does condom prevent cervical, prevent spread of HPV? I see condom promotion as a primary prevention. Do condoms prevent HPV spread?
I'll start, but others can join. Condoms are not 100% preventive of HPV. HPV can be transmitted, not just in the act of sex. Condoms can reduce the number of times you get exposed to HPV. So, I think the point is, I think generally risk factors are multiple sexual partners. The more you're exposed to HPV, the more likely the virus will stay in your body, or your body is not likely to clear it. Then you're more likely to get like an abnormal pap smear, or your VIA is positive. I think the point is everybody should be vaccinated. And it was mentioned in the chat, the vaccine is licensed for both boys and girls, because boys can also get HPV and can get penile cancer, can get throat cancer, but it's free for girls because the public resources are limited. But in the private sector, boys can be vaccinated. And then secondly, screening and treatment. So condoms reduces the risk factor, but it's not going to be the one thing that will prevent another death.
Yeah, sorry. So just for also my understanding, condom is more effective with HIV spread, but not HPV per se, right?
Absolutely.
Okay.
Exactly.
Okay. So we shouldn't confuse the message of HIV and think, oh, it protects even HPV. Okay, fine, got it. That's that. Thank you, Dr. Gigo, for making us discuss that and learning more about how to try and not the myths around HPV spread. So in that regard, Doc, you mentioned something very critical about boys being able to get cancers. There's a lot of questions on the platform about if a 25-year-old can get it, if a 17-year-old can get it. If I'm 25, why are you not providing this for us? So Lucy, since you're in the space of vaccine, kindly share with the audience why the age group has been picked and why it's being offered to female, and if it is advocated or recommended for all ages or gender?
Thank you very much, Dr. Amina, for that. Actually, this is a question that we get severally on why we've selected a certain age group when there could be some benefit in other age groups. Whenever we look at vaccination and selecting those timings, like when do you give a vaccine, when do you, who do you give it to? It's usually with an eye of public health benefit. So that vis-a-vis individual, benefit. So when we look at it with the public health benefit through that lens, we see that the maximum benefit for this vaccine would be between that age group of 10 to 14 years before sexual debut. And also this is the time it has been shown that the vaccine effectiveness is also high. That is, the immunogenicity will also be high in this age group. So that is why we find that we are pumping our resources towards this age group. And so that is why this age group was selected. And also because we know when we are targeting preventing cervical cancer, there are also other benefits to the boys outside, cervical cancer, the issue of genital warts and such. But our primary focus that we are looking at is to prevent cervical cancer. And that's why we are targeting the girls. So when we look at the public health benefit, then we have ended up with this age group. But it does not mean that individuals would not benefit. But when you look at the whole group, we now had the recommendation to target the 10 to 14-year-old girls, because this is where we would get the highest benefit. Thank you.
Thank you, Dr. And if I heard you correctly, it's a resource-based decision, and based on the resources, the most strategic group was the young girls who are 10 years. And maybe you can shed more light, because initially it started as 10 years. What made us broaden the scope from 10 to 14?
Yeah, when we started, we had hoped that when we started off, we would have started with what we are calling now the multi-age cohort, with the span of an age group of 5 years. And then we would continue with one age group, just the way we do for routine vaccines. We've done the same with other vaccines like measles, rubella. We started with a very big age group of 9 months to 15 years in a campaign. And then we continued with the 9-month-old. The only problem was at that time, other countries were also applying for the same. Tanzania, Uganda, they were all competing for, they all wanted to do a multi-age cohort. And the global supply was having issues. So because of that, Kenya was paused. And we were told either we wait until we get the supply, or we start off with one age group, and then when the supply is okay, we'll be able to have enough vaccines for the other age groups. So we opted to start off with the 10-year-olds, because better you start with what you have in hand rather than wait. So we started off with the 10-year-old, and then we got to the 10 to 14 once the vaccine was available. So that is where we are. Currently, we have enough vaccines. Unfortunately, now the people are not coming. And yet back then it was a supply challenge. So we are in a opposite situation. Thank you.
Thank you. And now my challenge was, can we widen it further so that the 17-year-olds who are asking for the vaccine and the 20-year-olds, it's not a question, Dr. Lucy, but it's just a thought process. Maybe we should consider increasing the age group, because probably there's a demand from people who are willing to take the vaccine from a bigger age group. So, Dr. Lucy, sorry, Dr. Mugo, do you have any input on that?
And the key thing is to, so resource, competing priorities, as many people here who are healthcare workers realize, every day, should the government hire more nurses? Should the government, invest in XYZ? There's so many things that need to be invested. So it's a public health good. But one thing we all need to advocate for is for those vaccines to be covered in the private sector. So insurance, for example, should cover the vaccine based on health need, not so the government is allocating its resources based on the fact that it has a limited amount of money. But for example, if you have private insurance should cover based on health need. So if you have a son and your insurance covers your children, then your son should be able to get vaccinated through the insurance. So I think this is part of ensuring all sectors are part of this elimination agenda, and making sure that insurance companies cover the vaccine based on need, on health benefits. So everybody should, both boys and girls should get it. I think the question of if vaccines are they're not being utilized, ideally they should not expire. So maybe we need to think about how do we become flexible so that if a 17-year-old walks to a facility and there's many vaccines, maybe she should get it. I think these are things that especially when we make policies, we should be flexible with that. But the key message for healthcare workers is that both boys and girls should get the vaccine. And again, as part of that flexibility, perhaps we can build in the flexibility of giving it to boys if there's not enough girls. But when you go to a gynecology ward, or in general, cervical cancer is the second most common cancer. So we need to figure out why is it that young girls are not getting vaccinated. Somebody mentioned, some of the community myths. How do we, especially in conservative communities, how do we get ambassadors who are people from those communities who can go in and they're trusted, so that we can make sure these young girls who are the most susceptible, they're the ones most likely to present, dying. How do we address the issues that are preventing, that 90% uptake of vaccination by young girls?
Okay, so just to understand, after taking the vaccine, when you're 10 years old, do you still need to do your screening when you're 25?
You do need to do your screening. I think Dr. Lucy Mecca mentioned, there's about 30 types of HPVs out there. And we have a vaccine that either covers 9 of the key HPVs or another vaccine covers 4. So we cover the HPV types that are the most common and the most likely to cause cancer. But for example, somebody mentioned in the questions about genital warts also caused by HPV. So you do need to continue screening. But science is always evolving. So as more cohorts are fully vaccinated, it's likely that the screening recommendations will change. So, the way we'll be screening 30 years from now, if all our girls are fully vaccinated, is going to be different because the burden of disease will be very different. But for now, screening continues to be the same until we have enough data to show for who the screening can be, changed.
Okay, so we've discussed a lot about screening, education, and I wanted to talk more about the advances, what's new in the country in terms of treatment. Lillian, maybe you can give us a brief of the new radio oncology services in the country, where they're available, and what's the progress so far?
I don't know, I did not get the last part of your question.
The new services that are new in the public sector in terms of offering radio oncology services to patients.
Okay, as I had mentioned that we have trained them on lip treatment. And again, okay, other treatments are the thermoablation and cryotherapy. Those are the type of treatment that are offered during a precancer state. And when the lesion is above 75%, now the gynecologist comes in with the treatment of lip. They are currently being trained on a colposcopy, where most of them are able to do colposcopy, but we still, since we are giving them the colposcopy machines, so we are also doing that training just to familiarize themselves with probably a new type, or yes, yeah, that is what is currently.
Yeah, sorry, Lillian, I meant in terms of radio-oncology, like MTRH opened in 2020, Nakuru, Garissa, the radio-oncology. For Dr. Lucy, you can. Sorry for the misunderstanding. Maybe just to proceed because of time. Thank you very much for giving us this overview and updating us on where we are. Can we give parting shots? And we'll start with Lillian. What's your parting shots? What is your message for the audience? Where would you want to highlight for us as healthcare workers to strive to be better?
Okay, thank you everyone for joining the call. My parting shot, I would say that if we do screen our girls, if we do vaccinate our girls at the appropriate age, we will not get these cases. So I'm just encouraging the audience that we keep with the advocacy of cervical cancer, since it is the eliminatable cancer and it's the only cancer that is treatable. We are able to eliminate it from our country, starting with the girls, then we go screening the women, and also we treat the lesions that we find on the way. And if there is a disease, you encourage treatment by all means. Thank you.
Thank you, Lillian. Dr. Lucy?
Yeah, thank you so much for this opportunity. I think on our end, it's just to emphasize again what Lillian has said, that let us vaccinate these girls at this age group. Let us focus our energies to getting these 10 to 14-year-old girls. Where are they? Let us get them. Let's not miss them when we encounter them, so that we get them at the right age and we have the maximum public health gain even as we vaccinate. So we keep our eyes on the ball and focus on this age group for vaccination, and the other interventions for the other age groups, we also keep up at them to ensure that we have reached the goals that we mentioned there, so that our people are protected and we're able to reduce the deaths that we are seeing. We'll be able to see this gain in maybe the next 20 years. So whatever you're doing right now, know it is for the next 20 years. So look forward to that, and let us go forward together. Thank you.
Thank you, Dr. Lucy. Dr. Mugo?
I think, yes, my main message is, especially for healthcare workers, is to limit missed opportunities. Similar to what others have said, any encounter you have with a woman in the hospital, ask her if she's been screened, offer a direction. If she has girls, make sure she's getting vaccinated. The more of us spread the message, and we really strive to limit missed opportunities, coupling vaccination with, other community-based campaigns, MCH, spreading the message, then eventually we'll start to see less women dying from this preventable disease. Thank you.
Thank you, Doc. But if I might just add, let's go screen ourselves. Let's go get our children screened, because you'd be surprised at the number of healthcare workers who have not screened. So if you haven't done it this January, you can do it as your New Year resolution. And I guess if you do HPV, you don't have to do it in 5 years, correct? Yeah.
Yes,
If it's negative and you are HIV negative.
if
Yes.
you're HIV negative, you only need HPV testing once in 5 years. Yes.
Yeah. So thank you very much, all the presenters, for taking your time for teaching us. Tomorrow we'll have a session on medical certificates of cause of death. We normally, there's a lot of complaints on what we are writing on medical certificates. So kindly join in so that we can know how to be able to write it correctly. Dr. Walong is there to take us through it. And on Thursday, we are going to have a new upcoming series whereby we engage other professions from other industries to teach us and elaborate things on us. And she's a drafter, a lawyer, one of very few. She's called Annette. And tomorrow, after the session, we will share some questions, a form for people to fill in case they want to know, to ask questions prior, so that she can make more arrangements on drafting of laws, of bills and acts. So thank you very much, everybody. For, as usual, you can get a copy of this uploaded on our YouTube channel, and follow us, subscribe. It makes a big difference. And please follow us on Twitter as well for any updates and more engagements. Thank you very much, everybody. Have a lovely afternoon. Bye-bye.